Welcome, everyone. It's the Friday edition of Brain Turns. I got really close to the camera there. This is not a good look for me. All right, today we have a super special session, and this is actually going to be one of the highlights, I think, of this whole 8-week series. We're fortunate enough to have School of Medicine students from Zucker School of Medicine delivering anatomy lectures to you guys. And so, like I said on the first day, it's not medicine without anatomy. And this is going to be a good foundation. It's going to help you guys understand a little bit more of what people are talking about. And also, the more you hear things, the more you're going to learn them and the more it's going to stick. And so we have an expert panel of anatomists who are going to give you guys a good, straightforward, I think, educational session and series over the course of the next 8 weeks. I think one of the big things is that obviously the chat feature is fantastic. We're going to try to hold our questions to a question and answer session at the end. As always, I think, questions will come through. We'll do our best to answer them. But right now there are 554 of you and climbing. And you can imagine if everyone has a question, it gets a little overwhelming. So with that, I'll be back around 10 just to say what's up and introduce Langer again, but he needs no introduction. And he'll be given the first of the chairman's corner. And I'm going to let the med students introduce themselves and tell you a little bit about what they have planned for you. So good luck, guys. Have a great time. They're hungry for education. And so go wild.
Thank you.
Okay, let's see if I can just share this. Okay. Hello.
Hi, everyone. So we just want to take a quick moment to introduce ourselves. My name is Maddie Abrams. I'm a third-year med student at the Zucker School of Medicine at Hofstra Northwell. I actually had the opportunity last summer to do research specifically with Dr. Bookvar, but I've had a chance to work with the entire neurosurgery department and the whole team, and I can just say that you guys are so lucky to have this opportunity this summer. Obviously, Corona has flipped our world upside down, but the silver lining is that you guys had the opportunity to do this, so I hope you guys are excited.
Yeah. Hey guys, I'm Julia. I'm also a third-year medical student at Hofstra, like Maddie. I sort of developed my interest in neurosurgery through also doing research last summer at Northwell, and also along with Brendan, who's one of your instructors, who you'll meet very shortly, was able to help start the American Association of the Neurological Surgeons chapter at our school, which is really exciting. So Maddie and I are actually here just to get you guys sort of kicked off. This might actually be the last time that you visually see our faces. We're going to be more behind the scenes people because our rotations are actually starting this coming week, but we're excited to hand things off to a great group of instructors and medical students who have worked hard to give you guys a really great course over the next several weeks. So we're just going to start by introducing what this course is. Maddie?
Yes. So the goal of this course is, this is a beginner course. It's not meant to be a full intensive anatomy course, but it's meant to give you guys kind of an overview of anatomy so that you can build the foundation so that when you take classes in the future, you go in with, a baseline level of knowledge. So the structure of the course is that each week is going to be a different seminar focused on a different body system. And as Julia mentioned, you'll have a group of second-year medical students who will be teaching it in groups of 2. So you'll get to see a couple of different faces week to week, which will be really great to have exposure to a bunch of different people.
Okay, and with that being said, so what are you going to be learning each week? So this is the syllabus. So the first week, that's today, you guys are going to sort of just get oriented with anatomy language. So you're going to hear the goals listed in front of you. So you're going to understand the role of gross anatomy and medical imaging, and then an anatomy component of the curriculum, and you're going to learn basic terminology to actually describe anatomical relationships between structures in the body, and you will get introduced to radiographs, X-ray, CT, MRI scans. And then next week, you're going to do pulmonary structure. So it's going to be all about the pulmonary system, its relationships with the chest cavity. You're going to learn surface anatomy landmarks, and actually be able to correlate that to imaging studies as well. Maddie.
So week 3, you guys are going to be learning about the cardiovascular structure. So that's the heart and all the blood vessels. So you'll learn about the anatomical relationships within the thoracic cavity and all the organs inside the viscera. You'll be able to describe the internal and the external structures of the heart, and you'll be able to talk about the pathway of blood through the circulatory system. Week 4 focuses on the abdominal and pelvic structure. Through this, session, you'll be able to discuss the anatomy and the relationships of the abdominal and pelvic cavities and the structures that are within them. And you'll integrate the surface anatomy, physical findings, and imaging techniques in order to have a kind of clinical idea how to approach the abdomen and the pelvis.
Great. And then week 5 will be about musculoskeletal system. So you're going to learn the general organization of the extremities, the fascial compartments, the way joints move. You're going to be able to relate the bony and soft tissue morphology of joints to their surface anatomy and function. And then week 6 will be about head, eyes, and neck. So HENT structure and cranial nerves. So that'll be understanding the anatomy of head and neck structures, correlating the findings of the physical exam with the functions of the cranial nerves, and that will be very interesting as well. Then a couple of extra weeks, Maddie.
Yep. And then finally, the last 2 weeks are our big concluding weeks, most relevant to what this whole course is. So week 7 is going to be of the CNS, which is the central nervous system, and focus mostly on the brain. So you're going to be able to describe the external anatomy of the cerebral hemispheres of the brain, the lobes, and all the features of the brain itself. You're going to be able to talk about the arterial supply and the venous drainage, so how blood gets in and out of the brain. You're going to be able to correlate the structures and the regions of the brain with their findings, so how one part of the brain lets you do a specific movement or anything. And the last thing is you're going to be able to describe the organization of the meninges. And for the final week, we're still focusing on the CNS. So the 2 parts of the CNS are the brain and the spinal cord. And so the last week will be the spinal cord, and you'll be able to understand the organization of the spinal cord and the peripheral nervous system, so the PNS. You'll understand the differences between somatic and visceral organs of the body, and contrast, the way in which they receive innervation from the body, and you'll be able to understand the role of the sympathetic chain in visceral motor innervation. And so that was kind of our just quick overview of everything you guys are going to be covering. The second years really put this together themselves, and with that, we'll let them take over and start your first session. So we really hope that you guys enjoy this that they put together for you. It's really going to be an awesome experience. Thank you.
Thanks.
Cool, thanks guys. So I guess we'll start by just introducing all the instructors. We have 2 per week, and each pair is going to be covering 2 weeks, like Maddie and Julia said. So can Ben and Madison get us started, and then we'll just go by week.
Ben, if you want to introduce yourself before I start.
Sure. So, hey everyone, my name's Ben. I'm a 2nd year medical student at the Zucker School of Medicine at Hofstra Northwell, like all of us here. Madison and I are going to be teaching you this first session here, and I'm going to hand it off to her right now.
Okay, great. Okay, yeah, so I'm Madison. I'm a 2nd year medical student at the school as well. So I'm just going to be starting with the first portion of today's presentation, and then Ben will take it off. So let me just share my screen.
Yeah, before we do that, I wanted each of us to kind of introduce ourselves. Can we do that?
Okay. Yeah, we can do that.
Yeah, so.
Did you want us to say like anything else about ourselves?
I mean, you guys are going to be kind of continuing on after like the introduction, so the floor is going to be all you guys.
Okay.
So yeah, I guess I'll get us started too. My name is Brendan Rue. I'm also a rising MS2 at Zucker School of Medicine, Hofstra Northwell. I know it's a handful to say. I'm supposed to be here with Morgan Crush. She's also a colleague. She couldn't make it today, but I know I can assure you she's also very excited. It's really a pleasure to be able to kind of teach you guys anatomy. It's truly is one of the most important parts of medical school, because without anatomy, you wouldn't have physiology. So I know this isn't the most ideal platform, but we'll try to be as engaging as possible to have a good educational experience for you guys. Yeah, and I'll be teaching pulmonary structure next week and CNS structure, specifically on the spinal cord of week 8.
Hi everyone, my name is Marianne, also a rising MS2 at the Zucker School of Medicine. Myself and Sabrina, you're going to be seeing us the 3rd week, where we're going to be starting the introduction to the cardiovascular system. So I'm excited to see you all in a few weeks.
And then hi, I'm Sabrina. I'm also a rising 2nd year with pretty much everybody else here. And then I'm joining Marianne to teach you guys cardiovascular structure. And then what is personally my favorite is CNS structure of the brain.
Hey guys, my name is Joe, also rising MS2. I'll be working with Sal and we'll be teaching you abdominal and pelvic structure in week 4 and then MSK in week 5.
I am Sam. You can also call me Sal. As Joe just said, we're going to be working on the abdominal pelvic structure as well as MSK. Excited to start working with you all.
Okay. Are we ready to start then?
Mhm.
All right. So if you guys haven't seen the message, you can get this PowerPoint on the drive that was posted in the Facebook group, and Ben just also posted the link in the chat. I would ask that you just follow with the screen share for now. That way, like, none of the answers are revealed to any questions that we ask, and just use the PowerPoint that's posted as reference later. So let me share my screen. Can you guys see this right now? Sorry, give me 1 second. Sorry, this is my first time sharing a screen. Okay. Actually, Ben, would you be able to share your screen?
Yeah, I can do that.
Just because it won't let me grant access while I'm still on.
All right, do you see this?
Yeah, and then just enter presentation mode if you can.
Yep.
Okay, lovely. And there's like some animation, so you'll just have to like click through as I'm talking.
Okay, yeah, I'll follow.
Great. Okay, so week 1, we're going to be talking about just an introduction to anatomical terms and some forms of imaging that you'll see throughout the course. So you can go to the goals, Ben. Yes, this is day 1. Okay, so the goals for this week is to understand the role of gross anatomy and medical imaging in the anatomy component of the curriculum. Use basic terminology to describe anatomical relationships between structures in the body, and then identify the anatomic planes shown in radiographs and distinguish between the appearance of X-ray, CT, and MRI scans.
Yeah, so I guess like one thing to add is that like this first week, this session is really kind of like more basic to get you kind of set up for all the other weeks so you can get the most out of them.
Yeah. So you're not expected to learn, like, we're not really learning anatomy today so much as we are learning anatomical terms and kind of the basic forms of imaging that you'll be using to learn anatomy. So physicians use a wide range of imaging techniques in order to assess the anatomy of their patients. So when you go to the doctor and you have a problem, typically one of the things that you get done usually is blood work and a physical exam, but then the third component is that you usually get some form of imaging done, and your physician will pick that form of imaging depending on what they need to see or what part of the body they need to see. So some examples of these forms of imaging are X-ray, MRI, CT scans, ultrasounds, endoscopies, and PET scans, which are nuclear medicine. In this course, you'll probably most frequently see X-rays, MRIs, CTs, and ultrasounds, just because those are the most frequently used, and those are kind of what you'll become familiar with as if you go into medicine or if you just are learning anatomy. So you can go to the next slide then. Okay, so I have a few examples of these imaging forms on this slide, and let's start with the top left one, if you can use your mouse, Ben. And I just wanted to ask which imaging modalities are each of these, and you can just put it in the chat if you know. Yeah, very good. Okay, I see a lot of people saying X-ray. Yep, this is an X-ray. And let's go to the next one. Does anyone know what this one is? ultrasound, good. And what you're seeing in that ultrasound is the liver, just for reference, if you're like, what am I looking at right now? Okay, and what about the next one on the very right? PET scan. Yes, wow, okay. You guys are very good. Okay, and the bottom left one? CT, yeah. And what about the one next to that? MRI. Yeah, that one's kind of a giveaway because you can see the brain really well. And what about the one on the very right bottom? Endoscopy. Yeah, endoscopy is a little different because it's not so much as like an imaging form as much as it is like a camera going inside of you so you can see the anatomy in real life. So you'll focus more on endoscopies when you do the GI section of this course. You can go to the next slide then. Okay, so we're just going to talk briefly about the advantages and disadvantages to each method. So the first one we're going to discuss is X-rays. Can anyone tell me what the advantage to getting an X-ray would be? Quick, cheap, yeah. Low radiation. Yeah, you guys basically said everything that we had on the slide, so you can click forward then. Yeah, so the benefits to an X-ray are that it, like you all said, is that it's quick. It can be done, you know, in a matter of minutes, which is really great, especially in a setting where you want a quick result. And it's non-invasive, it's painless, it doesn't really hurt anyone to get an X-ray. There is a small amount of radiation exposure, but it's less than the other methods, as you'll learn. So it's a little bit better to use in children. And what are some scenarios that you think you would use an X-ray? So I'm seeing a lot of bone fractures, broken bones. Yep, that's the typical one that you would get an X-ray for. Yeah, so I'm seeing a lot of people saying lungs and chest as well. That's definitely probably, you know, the second most common use for an X-ray. As you can see in the top right corner, the image is a chest X-ray. And so a chest X-ray is really good because you can kind of see the lungs well, and you can see the heart well. At least you can see the outline of the heart well. So if there was like a consolidation of pneumonia, you would see it in the lung very clearly on a chest X-ray. And likewise, if there was air, which can happen if you have a puncture in the pleural cavity and you get something that's called a pneumothorax, you would see a big black space on the chest X-ray in the lung area. And if the heart was enlarged, you would see this outline of the heart would probably, you know, be skewed to the right or left depending on the problem that was happening. So there's a lot of things that you can see on a chest X-ray. And like everyone else said, kind of the classical use of an X-ray that most people know is for broken bones, which is what this second image is. Yeah, so I think we covered everything for an X-ray. So let's go to the next one. So there are some more specialized forms of X-rays that kind of use dyes or special imaging techniques to look at specific parts of the body. Does anyone know what this first example is? Angiogram. Yeah, wow, you guys are really good. So the angiogram on the left, Ben, you can click forward like as it's going. You'll see. Yeah, so angiograms are a form of X-ray that are typically used to see vessels. What happens is the physician will inject dye into one of your vessels, and then that'll travel to the specific organ that you want to image. So the left image is a heart angiogram, and the right image here is a brain angiogram. So if you have a problem with a vessel, such as like an obstruction to blood flow, this type of X-ray technique can be really great for seeing, you know, a blockage in blood flow, because you would be able to see the blood isn't running to a vessel that you know is supposed to be showing up on this angiogram. So go ahead, click forward one more time, Ben. Yeah, so this is another technique. Does anyone know what we're seeing in this image? Mammogram. Yep. So mammograms are also something that you've probably heard about in common life, just because a lot of women start to get them, you know, once they reach age 50, routinely to monitor for breast cancer. So yeah, a mammogram is actually a form of X-ray. You can click forward one more time, Ben. Yeah. Does anyone know what this top right image is? Barium swallow study. Yeah, this one's a little more obscure. You might talk about this more in the GI session, but a barium swallow study is where you actually swallow this type of contrast, and then you're able to see parts of the GI tract. Specifically what's shown here is like a narrowing in the esophagus. So this is really good to see if everything's moving correctly through the GI tract. And this uses X-ray imaging. And then the bottom one I wasn't gonna ask because this is definitely a lot more obscure, but the bottom image is a pyelogram, which you can use to see the bladder and kidneys. And the dye is injected form, so through the urethra, and it goes up through the bladder and up to the kidneys. And this is good because it can help show an obstruction in a ureter or in the urethra, or if you have any sort of urinary problem. So these were just some examples to show you, how wide-ranging X-ray is, and all these different types of specialized forms you can get. Does that differ from cystoscopy? The pyelogram uses cystoscopy when you're doing it, so it's a combined technique. You can go for it now, Ben. Okay, so the next form that we're going to talk about is the CT scan. Does anyone know some benefits of a CT scan? Painless, quick, depth, cross sections. Yeah, better resolution. Yeah, yeah. You can click forward, Ben. Yeah, so you guys kind of got the gist of the CT scan as well. It is also quick and painless. It's not as quick as an X-ray, and I wouldn't say it's as painless as an X-ray, especially if you have to get contrast, because then that can be through an IV, and that's not necessarily painless. And I mean, a lot of people get like burning at the injection site. So it's just slightly more invasive sometimes than an X-ray. But the benefit to getting a CT scan is that you can identify a wider range of conditions due to the fact that you get this cross-section, and you also just get more detail. So it's better for seeing your internal organs at a higher resolution. And like I said, the main disadvantage is that sometimes you have to get dye infusions, and you can get potential reactions to that dye. Also, there's higher radiation, which is not as safe for children or pregnancy. So you'll see a lot of times physicians really try to limit how often a child or someone who's more high risk is getting a CT scan for that reason, because repetitive CT scans over your life kind of increase your risk of cancer due to that radiation exposure. And a CT scan is just slightly more expensive, so when it can be avoided, it's preferable too. And what are some indications that you would use a CT scan for? Cancer, head trauma, bleeds, bleeding. Yeah, so I see a lot of the things that you guys are talking about I see cancer and I see internal bleeding, which are two really big things. CT scans are particularly good for, finding the specific location of a mass, especially in the abdomen or thorax, because you can see these cross sections really well. So you can kind of see like where exactly a mass may be lying. And it is really good for seeing internal bleeding as well. Say a trauma patient comes in and you do a CT, you'll be able to see where blood has gathered in the abdominal cavity or in the chest cavity. The picture shown here is of the lungs, and you're actually seeing structural changes to the lungs due to emphysema in this picture. That's what's circled here. So one of the other things I have listed that's really great for seeing on CT is these specific changes to organs. So here you can kind of see that the alveoli and the sacs in the lungs have been damaged. And so you can kind of, when you get those cross sections through the body of a CT, you can kind of see like very specific structural changes. Or you can see, if you're using dye, very specific blockages in vessels. which can be really useful for something like a pulmonary embolism, because you will be able to see that the dye isn't flowing through the pulmonary artery. So yeah, these are just a few things that CT is good for. Does it have a role in appendicitis? Yeah, you can identify appendicitis on a CT scan. There's a lot more methods that are being more used for appendicitis just because it's so common, but that you guys will probably might talk about that during the GI week. How long does a CT scan take? I'm not sure how long a CT scan takes. I think maybe like 15 minutes, 15, 20 minutes, I would say, but I'm sure the process is a little bit longer. Okay, you can go to the next one, Ben. Okay, so the next one that we're going to talk about is ultrasound. What are some benefits of ultrasound? Quick, yeah, the key to ultrasound is the no radiation part. So that makes it particularly useful for children in pregnancy, which is why women who are pregnant get ultrasounds to monitor fetal growth. And I also saw that someone said it's more of a live look at the inside of the body, which is true. I didn't list that, but that's actually a really good point, is that when you're doing an ultrasound, you're getting kind of a live view of what exactly is happening in the body right at that moment. And you can kind of capture a video instead of, you know, a still image. It's also very portable. They've made ultrasounds now so that you can kind of just put a probe into even an iPad or a tablet and carry that around the emergency department so that you don't have to lug around like a big machine or anything. So they're getting really portable. Unfortunately, with that, the resolution and the quality of the image you get has gone down. So that's the main disadvantage of getting an ultrasound, is that you don't really get as many details, but when you want kind of a quick look at something or a broad overview, an ultrasound can be really great for that. And so I mentioned one of the indications for ultrasound, which is pregnancy. Does anyone know what else you would use ultrasound for? Yeah, you guys are listing a lot of things, which is great. Yeah, so you guys are have talked a lot about masses, gallstones, kidney stones. Yes, those are all great things that ultrasound can identify, especially if things are calcified. You can kind of see like these white masses or white spots on ultrasound that can help you identify if there's like a calcified kidney stone or gallstone that's blocking. You can also use it to monitor blood flow. I saw that a couple times. Valvular defects in the heart. Yeah, you can use ultrasound to get a good image of the heart as it's pumping in real time. So it's good to identify problems with flow in the heart, seeing cysts. Yeah, so you guys pretty much covered all of it. So we mentioned pregnancy. Another thing is quickly checking for internal bleeding. There's something that's called the FAST exam that they do in the emergency department, where you do an ultrasound scan kind of quickly throughout the abdomen and the chest region to see if there's internal bleeding in pockets that are most common. Like you would check the liver and the spleen and kind of be able to see if those have been damaged. And on ultrasound, you would be able to see that fluid buildup and get them into surgery quickly, as opposed to sending them through a CT machine, which may take a little bit longer. And then the last thing that I just listed here is that there's a lot of ultrasound guided procedures. So a lot of times they'll use an ultrasound probe to do something where they have to insert a needle and remove fluid from certain cavities. So ultrasound guided procedures are really good to be able to look at what you're doing without actually opening up the person. So instead of going into surgery and, you know, like removing fluid that way, you can just use a needle and use the ultrasound to make sure the needle's going exactly where you want it to go in the cavity. So ultrasound is really good for procedures like that. Okay, and then we just have a little bit of an activity here. So I'm just gonna go over some cases and I'm gonna have you guys suggest which imaging would be best. So case 1, a 40-year-old woman with a history of smoking presents in the ED with a 5-day history of productive cough, fever, and chills. You hear a consolidation in her right lung during the physical exam. She states that she is producing yellow-green sputum, which is mucus, when she coughs. So what type of imaging do you guys think would be most indicated for this patient? X-ray. Yeah, my main thought was X-ray, mostly because she looks like she's presenting with something that's close to pneumonia, or at least some sort of lung pathology. And as we were talking about earlier, you can kind of get a good look at lung infections on X-ray if you do a chest X-ray. So if she had that sort of consolidation, you would see that quickly on a chest X-ray. And it's good to start with that, given that there's not as much radiation. What is a consolidation? So consolidation is essentially you have an infection, specifically a lung infection. All of the infiltrate that you get, which is like inflammatory cells, mucus, all of the things that are part of the inflammatory process kind of consolidate into what appears to be like a foggy mass on X-ray. So when you have an infection, you'll be able to see like this mass of inflammatory process, which is essentially like mucus and inflammatory cells, and that's very common in pneumonia. And yeah, the ED means emergency department. Sorry for that. If there's ever abbreviations, feel free to ask. Okay, we can go to the next case. Okay, so case 2 is a 65-year-old man presents to the ED with severe radiating chest pain to his jaw and arm. He is sweaty and anxious. You suspect a blockage in one of the arteries of his heart causing a heart attack. So what imaging modality would you guys use for this? Yeah, angiogram. Yes, good job. So this is kind of a little bit of a trick because it's like a part of X-ray since it's a form of X-ray imaging. But yeah, an angiogram, as we talked about during the X-ray session, is really good for seeing vessels of the heart. So with a heart attack, you would have a blockage in a vessel of the heart, usually one of your main coronary arteries. And with an angiogram, you would be able to see that blockage and then, get this person into surgery, specifically into a cath lab, usually to remove that blockage and treat the heart attack quickly. So if you're suspecting a heart attack, an angiogram is kind of like a good thing to go to first step, as opposed to doing other steps first. Okay, so case 3, a 1-year-old infant presents to the ED with continuous vomiting and crying. She appears extremely distressed when you touch her abdomen. So what type of imaging for this? Ultrasound, wow, okay, yeah. Woo, everyone said ultrasound, good job. Yeah, and a few people mentioned the reason you would get an ultrasound for this patient is just mainly due to her age, because it's a 1-year-old infant. So you don't want to be exposing an infant to radiation if you don't have to. She's not coming in with a broken bone, so you don't need to, immediately bring her to X-ray. So an ultrasound is a good place to start. Specifically with this sort of presentation, it's kind of indicative of a blockage in the GI tract. And that's something that you would be able to see on an abdominal ultrasound. And ultrasounds are good for children too, because you place the probe on them and it's not that uncomfortable. So like they can move around and stuff without, being restrained. Like you would have to have them stay still for a CT or X-ray. Whereas with an ultrasound, you have a little bit more flexibility if the child's like crying and flailing everywhere. But yeah, after you would do this ultrasound, you might move to an X-ray or a CT depending on the pathology that you want to see, but an ultrasound is a really good place to start to make sure that you don't have to move to those things that would expose a child to higher radiation first. Okay, good job, everyone. And I'm going to pass it off to Ben now to do the second part.
All right, everyone. So good morning. So in this second half, we're mainly going to talk more kind of like anatomic terminology, kind of words that like you'll be hearing throughout the rest of this course, including the use of the various planes of the body. So I just want to a quick show of hands. How many of you think would say that like you're pretty comfortable using these kinds of words to kind of describe anatomic relationships or things like that. I think you're able to raise your hands, right? All right, great. So then in that case, it looks like, we have a combination. Oh, whoops. Let me get back to my slide. We have a combination of experiences. So I think, so let me start off by just saying, so the reason that we have these terms is so that you can be kind of as precise as possible with your, descriptions of where things are. So if you say, oh, this blood vessel runs over this nerve. Well, what does over mean? Is it over when the patient is lying down, when the patient's standing up? So you want, these kinds of terms to describe relationships between structures, no matter like what position they're in or whatever. So when you use these words, for example, you see the words medial and lateral on the left side of the person. So medial means closer to the midline, and lateral means like closer to either side. And this is something that's really useful when you have structures that are, on either side of the body. So for example, your kidneys are on either side, both sides of your body. And then if you wanted to say, the part of the side of your kidney that's more on the inside, well, that's the right side of your left kidney and the left side of your right kidney. So instead of saying all that, we just say the medial side of your kidney to refer to both. And then same thing with lateral. Instead of saying, the rightmost side of the right leg or the leftmost side of the left leg, you say the lateral side of the left and right legs, and they'll know what you mean. I'll, for this particular diagram, you can search this up on Google. If you look up anatomic terminology, it'll be helpful to have this diagram pulled up for some of the exercises that we'll do going on. And yeah, so someone just brought up a really good point. So one of the reasons I don't really like this particular image is because this is not technically anatomic position. In anatomic position, you would have the palms facing outwards towards you. And so when the palms face forward, in which direction are the palms facing using one of these anatomic terms? So instead of forward, yep, the palms are anterior in the anatomic position. Very good. So, just as I said, there are two ways you can use these words. So for example, the one I'm giving you, the one I'm giving you is, the spinal cord is posterior to the heart. And someone had a good question too, the difference between superior, inferior, and proximal distal. So superior, inferior refers more to, a person's like kind of head versus their kind of tail, cranial caudal. So up versus down in a person in an anatomic position. But proximal distal is something you use more for the extremities because, the arms can be in a lot of different positions. It's more helpful, it's more helpful, to use proximal to distal to refer to like, how far down the arm or leg you are, essentially. And then the other reason you can use these words is to, say like which side of something you're on. So as I mentioned earlier, you can say, you can have the lateral surface of the left thigh, or you can say, your hip adductor muscles move your thigh medially towards the midline. And then, as I said before, I have a couple of exercises, and feel free to pull this diagram up or another similar diagram if you've never seen this kind of terminology before. So, now I'm going to talk about the anatomic planes, and it's really important that you, be really familiar with these anatomic planes because they're really important in all sorts of imaging. To be able to see, predict what comes next, you have to know what plane you're in. And we exist in 3 dimensions, and as a result, there's kind of like one plane for each dimension that you can cut in. And the ones we're going to go in are the sagittal plane, coronal frontal plane, and the axial/transverse plane. You can imagine each plane as just sort of like an infinite like sheet that cuts into the body. It's the same kind of plane as in the kind of point line plane you learned in 9th grade geometry class. If you ever asked yourself, when your geometry class is going to be relevant in real life, well, this is one example. So, the first exercise that we can do is kind of this very simple one. So, my question to you guys is, which of these chambers of the heart is the most anterior based on this particular image? Yep, the right ventricle. So the reason that you know it's the right ventricle is because there are several hints. And one of the hints at the very bottom of the image is this, big white mass. And what do you think can be a really big white dense mass that kind of looks like a rod in someone? Yep, the spine. So as a result, that sort of clues you in at the bottom of the image there is kind of the posterior backside. And you see like a thin bone in the middle on the top, and that's probably the breastbone, the sternum that you see on the top. So as a result, if you get stabbed somewhere in the sternum, the right ventricle might be the first chamber that you have to worry about potentially getting, ruptured or something like that. But very good. And then, just to confirm, which chamber is the most posterior? It's probably a very simple question, so I apologize. Yep, the left atrium. All right, so on this particular little exercise, you can ignore the numbers on this particular slide. I'm just going to annotate with a couple of points here. So one thing I want to say is, so I'm going to draw like kind of a line aside, like side A, kind of a side like B, kind of a side C. So if you're talking about this, can you tell me which lung I just drew the three sides on, the left or the right lung, just to make sure everyone's on the same page? Yep, it's the right lung. And you can know that because you see the heart goes mostly into the left lung, as you see here. And then someone had a good question, is a CT only done in an axial/transverse plane? And the answer to that is not necessarily. A lot of the times an axial is one of the more helpful ones, but you can also have a sagittal CT or a coronal CT. And the other important thing is that when we talk about left and right, and Ellie had a very good point, you talk about it in the patient's perspective. So that's the patient's right lung that you always talk about. It's never from your perspective, it's always the patient. Or always like the body part you're looking in front of. All right, so now we established just the right lung. So out of the three sides that I just mentioned, can someone tell me which side of these would you consider to be the lateral side of the lung? Mm-hmm. And then what word would you use to describe this, side C? What word would you? Yep. So I see, yep, that's the inferior surface of the side of the lung, and then B is called what? Yep, B would be kind of the more superior. And then a fun fact is that, so in anatomy, the top of the lung is called the apex. The bottom of the lung is the base. But for the heart, it's sort of inverted. The heart's bottom is called the apex, and the kind of top of the heart is called the base. And that's something you kind of go more, later on in the week where you learn about the heart. But you can think about it as whichever end is more pointy, consider the apex. For the lungs, it's the top that's the most pointy, the most cornerish, so that's the apex. For the heart, it's kind of the bottom that's the most pointy, so that's the apex. And yeah, Josh, really good question. That's why it's superior versus inferior vena cava. So because it's superior, it comes from the top, and inferior comes from the bottom. Very good. So, if you had to so now let's use these numbers. So let's look at numbers 1 and 2, right? So if, let's say you had, a tumor at 0.2. How would you use, how would you describe the tumor at 0.2 in relation to the location at 0.1? Is it, superior to 0.1? Is 0.2 lateral to 0.1? Yeah. So, yep, exactly. So, 0.2 in comparison to 0.1 is a little inferior and also a little more medial as well, inferior medial. Very good. So then let me stop annotating. All right. Whoops, my bad. Okay, so let me erase all these annotations. All right, so for this particular one, can someone tell me what they think we're seeing here? Yep, so this is, an image of the legs. And what imaging modality do you think we used here? Yep. So it's a CT, and one of the ways you can know is because bone is really, really bright on CT, because CT is just a bunch of X-rays you like take over and over again. So in X-rays, bones are pretty white or pretty bright. And yeah, it's a CT. And yeah, I also said it. So so now that we said this is a view of the legs, so when you look at a CT, it's an axial CT like this, as someone pointed out really well. You always look at it basically from the perspective as if you're looking at it from the feet. So on one of the legs, I drew, four sides. Can someone tell me which leg that is, the left or the right? Yeah, that's the left leg. So it's really important that, everyone's on the same page about this. And then someone had a question, does blood also show up white on a CT? So blood and water, so water on CT is supposed to be like a rough, medium gray, but, and maybe a little bright depending on the amount of maybe hemoglobin there is. But, because it's not that bright, that's why you often insert like a radioactive contrast in order to make the blood appear brighter. And then Claire had a good question. How do we know it's the left? So on a CT, you always imagine it as if you're looking at it from the person's feet. So if you're looking at someone lying down and you're looking at their feet, then the one on your right is their left. So light gray and so the light gray and dark gray. So the light gray here is the musculature, but we'll refer back to this in later weeks. All right, and then so to continue with this particular exercise, let's see. So just to review, what side is side A? Now that we established, we're looking at this from a feet first view. What side is side A? Yep. Yep, it's the anterior. And remember, and if you said superior, in a vacuum, you might not be wrong. In this view, it's on the superior side of this image. But remember that the reason that we have this terminology is so that we can, use these terms unambiguously, no matter whether or not these people are lying down, sitting up, or whatever. So in that case, A would be the anterior side of the thigh because this person's lying down, and that's that side. And which side is side C then? Yep, side C would be the lateral side. And then what about side B? Yeah. So side B is has a combination of being both anterior and lateral, and so we call it anterolateral. And it's still something you have to learn with experience. Some of these words are better suited to becoming prefixes than others. For example, you always turn anterior and posterior into prefixes. You never turn lateral or medial into prefixes, basically. So we call them anterolateral. And then people had good questions about how we know A is anterior. So you can imagine on a CT scan, it's always someone lying on their back, and then their feet are facing you. So if someone's lying on their back, feet are facing you, you can assume that A is the anterior side, the side of their belly. Does that clear things up? Mm-hmm. And then superior, anterior, I think you would say antero-superior. Yeah. And then what about side D? How else would you, what would you call side D? Yep, posterior-medial. Exactly. And for those of you using the words inferior, remember that this is an axial CT, so the person's lying down, superior still refers to like the direction towards their head. Inferior still refers to the direction like towards their feet. But you know, since they're lying back, the top and down in this image correspond to their front and their back. All right. If A is anterior, is the person's anterior, you would always say A is the anterior side. It's on the superior, you know, part of the image, but no one ever says like, you know, it's on the superior side of the image. You always talk about it
giving anatomy lectures. No.
All right, so let me clear that. Yeah, and someone had,
You're
someone had
not
a great question.
Ben, do you want to tell him to mute? Dr. D'Amico. Oh yeah, never mind. You got it.
Okay. Oh, sorry. And so yeah, someone had a great question. When would you use an example of proximal distal versus superior inferior? So I'm going to draw something right now. So I'm going to draw like a patient's like arm on the side here. So this is like their kind of arm. This is their shoulder. Sorry, this is a very like badly drawn arm, like that. So there's an artery called the brachial artery that kind of runs alongside your upper arm, which then splits into your ulnar and your radial artery. So if you have a blockage of this artery at point A here, and then, you know, 5 months later, this person had a block on their ulnar artery at point B a month later, you can say that, you know, their like second block was distal because it's further out compared to point A. And that you can say that point A is more proximal compared to point B. Yeah. Does that clear things up? All right. So now I just wanted to know, just to kind of briefly introduce the planes, because this is something you really have to know kind of really cold. So in terms of the sagittal plane, so does anyone know what Sagittarius means? So yeah, Sagittarius means archer. And that's the reason I have this archer up over on the left. One way you can imagine, you know, the sagittal plane is as if that person is holding a really long bow in front of them. And if you're viewing them from the front, that bow would kind of divide them along the line like this. So on the right side here, you can see, you know, two examples of views in the sagittal plane. On the top right here, you can see an example of a cadaver cross section that is been cut in kind of a more mid-sagittal plane. Versus on the right, has this particular MRI been taken exactly in the middle of the patient or kind of more on the side? How can you tell? Yep, you can see there's an eyeball. So if you know there's an eyeball, you know that, you know, the cross section has not been, you know, been in the middle unless you have, you know, one eye in the middle of your forehead like a cyclops. But so yeah, that's an important point. These planes only tell you the direction that you cut, not exactly where you cut. And then someone asked, how do you know which side you're looking at? Can you clarify that question? No, I'm going to move on just for the interest of time. Oh, and then, left versus right. Oh, that, for example, for this one, you're seeing that person's kind of left side of their face has been cut out, for example. And then for the MRI on the bottom right, an important, like a side note is that, like, because you see the eye is really bright, the eye, since it's full of fluid, there are two kinds of MRIs, T1, T2 weighted. I'm not going to really go into that, but basically T1 is the water is dark, and then T2, the water is bright. So this would be like a T2 weighted MRI. Let me move on. So the next one Oh yeah. So Devin had a question. If it's so sagittal refers to all planes in that direction, even if it's not perfectly centered. If it's perfectly centered, you say it's a mid-sagittal line. If it's kind of on the side, you say kind of a parasagittal like plane. But in any case, those are all sagittals. And the next kind of plane that we'll go over is kind of the coronal plane, in that the coronal plane you just kind of view from straight on, as if you're viewing like a king or queen wearing a crown in their throne room. And then on the right you see cross section of a brain, a cut in the coronal section. And then on the bottom right there's a still shot from a very popular TV show that actually doesn't do a terrible job showing a coronal section of the face. And for reference, when we talk about Netter's lately, at the bottom right, actually, I think looks a lot similar to the Netter's image. And then, for example, in the middle of this, we have an example of a coronal CT. And then on the furthest right, we have the transverse or the axial plane. I don't have a way for I don't have an etymology or why it's called the transverse or axial plane, but basically, it's the one where you cut kind of like a cross section. It's one where you have a lot of CTs and being done in this plane, because it kind of lets you scroll throughout the entire body. And then, you see the kind of cross-sectional plane on the model on this top left here, which sort of roughly corresponds to where this particular CT was taken. And then Victoria had a question: are we always looking at it from the top? No, we're not. So as I said before, with a CT, axial CT like this, it's really good to imagine that you're looking at it from the perspective of the patient's feet. So if you're looking at it from their feet, you see like the whole, right side of the image is actually the patient's left. And then just to, reiterate, so for example, this arm right here would be the patient's left arm. Right there, because you're looking at it from the perspective of their feet. And then can someone tell me, so this CT isn't exactly where this image is. Can someone tell me, do you think the CT has been cut a little superior or a little inferior compared to this image right here? Yep. Yep, that's superior, because you can see, still see some ribs in this CT, whereas in this particular cut, you're kind of really low. You would expect to see maybe, the pelvic rim maybe, but you probably wouldn't see any ribs that far down on this like kind of 3D model. But in this one, you see kind of ribs and you don't see any pelvis, so you can kind of assume that you're a little far up. Yeah, and then I think and then on the right side, you have an axial image of the brain and the skull. And I think that's all I actually had for today. Let me exit out of this. Yep. So I just want to say, thank you. If you have any questions, feel free to reach out to, the emails that we have here.